Assalamu alaikum. Good afternoon from Malaysia. Can you hear me?
Yes, can hear, Prof.
Right.
We can
Thank
hear
you very
you
much.
well.
Yeah. I think it's the time we start this session. Thank you very much for joining the 39th MedEd webinar on teaching and assessing professionalism in health professions education. I think first we should look at the learning outcomes which we want to achieve in this session. After attending this webinar, the participants will be able to, number one, discuss the influences of religion, culture, and evolving societal values on the definition and scope of professionalism in health profession education. We know that the scope and definition of professionalism may not be static and it would change, especially with evolving societal values, and we will discuss about that. Second, explain the set of responsibilities to be encompassed in the Physician's Charter on Professionalism.
Yes.
Can everybody mute yourself, please? So our second learning outcome, explain the set of responsibilities to be encompassed in Physician's Charter on Professionalism, means what are the attributes of professionalism which we should include in our curriculum. Explain different teaching learning approaches for teaching professionalism in health profession education. Discuss different models of assessment of professionalism in HPE. And finally, the participants will be able to assess their own HPE programs in respect of teaching, learning, and assessment of professionalism. So hopefully by the end of this session, we will be able to achieve these 5 learning outcomes. So let's answer the first question. What is professionalism? This is a quote, a statement by Osler. You are in this profession as a calling, not as a business. As a calling which extracts from you at every turn self-sacrifice, devotion, love, and tenderness to your fellow men. We must work in the missionary spirit and with a breadth of charity that raises you far above the petty jealousies of life. Now, looking at this, you think you agree with this statement? Is it too much to ask? The self-sacrifice, the devotion, love, and tenderness, and missionary spirit with the breadth of charity. In first glance, it might appear that probably it's not realistic in modern times, at present times, but we will see how it fares along with our presentation. I remind my fellows, residents, and medical students that what we do is a privilege as a medical professionals. People let us into the most intimate aspects of their lives, and they look up to us to help guide them through very complex and delicate situations. So this is another important aspect of health professions, responsibilities, and the privileges. What is the operational view? What does professionalism demand from us in terms of clear instructions or clear attributes. Professional competence is habitual and judicious use of communication, knowledge, technical skills, clinical reasons, emotions, values, and reflection in daily practice for the benefit of the individual and the community being served. The word habitual means that is the second nature. It is expected that the health professionals, this is their nature, second nature, that they use different attributes, different skills, knowledge for the benefit of the individual and the community being served without really much thinking about it. That becomes their habit. So this is another view of health professionalism. What are the requirements of professionalism? Here is the statement by the Accreditation Council of Graduate Medical Education. And it says that residents are expected to demonstrate professional values such as respect, compassion, and integrity, a responsiveness to the needs of the patients and the society that supersedes self-interest, accountability to patients, society, and the profession, and commitment to excellence and ongoing professional development. So these are some of the professional values which are requirements of professionalism. The second, commitment to ethical principles. First was the professional values. And second is commitment to ethical principles pertaining to provision or withholding of clinical care. For example, a decision whether to ventilate somebody or not. Confidentiality of patient information, informed consent, and business practice. So these are ethical principles which form a component of professionalism. And then third is sensitivity and responsiveness to patients' culture, age, gender, and disabilities. So the Accreditation Council of Graduate Medical Education identifies these responsibilities or these requirements of professionalism. If we look it as an overview, so there are three major components of professionalism, which is behavior, skills, and knowledge. If we elaborate a bit more on that, the attributes of professionalism, it can be at the personal level, at the professional level, at the patient level, and at the community level. At personal level, it includes code of conduct, competence, leadership, and interprofessional skills. At professional level, excellence and commitment to professional development. This is very, very important, the lifelong learning. Professional traits. At the patient level, equity and humanity, patient primacy, and at community level, social accountability. The major concerns in professionalism include persistent inappropriate attitude or behavior, failing to demonstrate good medical practice, drug or alcohol misuse, dishonesty or fraud, aggressive, violent, or threatening behavior, any caution or conviction, and health concerns or lack of insights. So we have seen the positive attributes required for professionalism as well as negative elements which should be avoided if we want to have a really good approach in our professionalism. Now, looking at all these definitions, all these approaches, the question arises, does professionalism benefit only others, that is, individuals, community, patient, caregivers, or does it benefit the professionals as well? Of course, professionalism benefits professionals as well in terms of reduction in legal and ethical risks, contribution to personal satisfaction and reputation, improving mental well-being, maintaining work-life balance and boundaries, few of the many benefits which professionals can reap from professionalism. Now, having the concept, the requirement, the definition, the benefits, the positive attributes, and negative elements that should be avoided, let's look at the topic of how to teach professionalism in undergraduate medical education. Of course, we need to adopt approaches to ensure that understanding, teaching, learning, and appreciating professionalism becomes central and unambiguous component of training of healthcare providers. Means we have to give the appropriate importance, appropriate attention to this subject in our curriculum. The teaching frameworks should reflect the values, culture, traditions, and societal norms, along with community expectations from the medical professions. So our teaching programs, our curriculum should consider these points while preparing the contents of the curriculum. For teaching purpose, the first thing we need is to identify the learning outcomes. These learning outcomes may be personal qualities, values, attitudes, and behaviors, and identification of these learning outcomes will guide us to select the content of the training course and to align the teaching learning approaches with assessment methods. So, three major benefits of identifying the learning outcomes would be to identify the content that should be included in the training course and to find the appropriate teaching methods as well as assessment methods. So for any course, for that matter, learning outcomes is the first step to identify. Though the core values remain consistent as far as professionalism is concerned, there are some core values which would remain consistent. The changing societal norms need to be considered while defining the learning outcomes. This means that the learning outcomes may be different at different places, different geographical places, or different times because of the changing societal norms. Again, in addition to the previous requirements, a historical, cultural, religious, and philosophical view will enhance learners' understanding about the evolution of professionalism in the ancient Greece time of inception of Hippocratic Oath to present era, means how the concept of professionalism has evolved over centuries from the Greece time to the present era. The continuous professional and personal development is another important aspect that must be embedded both in the teaching and assessment methods. That is the concept of lifelong learning that must be a component of professionalism. The student must learn skills to continue to develop their professional identity throughout their career as a healthcare provider. Continuing with the identification of learning outcomes, the American College of Physicians, the American Society of Internal Medicine Foundation, the American Board of Internal Medicine, and the European Federation of Internal Medicine, all these organizations, they published a common physicians charter, which provides a comprehensive framework for professionalism to guide physicians. It addresses ethical issues, educational and practical issues, and can be a very, very useful guide if we are developing our curriculum about the professionalism and we want to identify the learning outcomes for our program. The professional responsibilities identified in this charter include professional competence. Number one, that means the professional exhibits lifelong learning skills to maintain medical knowledge and services. Number two, honesty with patients, means provides complete and honest information, including reporting of medical errors. Three, patient's confidentiality, avoids unprincipled disclosure of patient's information. Four, maintaining appropriate relationships with patients and their caregivers, means, for example, avoids sexual advances and financial gains. Five, improving quality of care, makes conscious efforts to reduce medical errors and increase patient safety and optimizes outcomes. Six, just distribution of finite resources, practices wise usage and cost-effective management of limited clinical resources. Seven, scientific knowledge, promotes research, creates new knowledge. Maintain trust by managing conflicts of interest, that is, recognizes, discloses, and deals with conflicts of interest. Then professional responsibilities, collaborates respectfully, participates in processes of self-regulation and standard setting. So these are 9 broad learning outcomes of teaching professionalism, which were identified in the physician's charter, and they can be very, very helpful for us if we start this exercise. Apart from that, another report from the Royal College of Physicians, UK, underscores the significance of expertise and proficiency as a vital constituent of professionalism. This is one aspect which many other definitions have not addressed. The knowledge and the skills, expertise and proficiency. And Royal College of Physicians, UK advocates that this should also be included in the learning outcomes. It stresses the need to focus more on, number one, leadership, teamwork, teaching and assessment skills, and the management of health providing professions in medical curricula and training programs. So Royal College of Physicians UK report advocates these attributes, these components to be included in the curriculum for teaching professionalism in the training programs. Now, after going through that, once we have identified the learning outcomes, we must make sure that the learning outcomes reflect the institutional values. Means, although we have gone through the literature, we have seen recommendations by different institutions, but at the end of the day, we have to see that the learning outcomes also reflect our institutional values. And once we have identified this, they must be agreed upon by all the stakeholders, including learners and teachers. Because otherwise, this implementation of teaching and assessment process will face many, many challenges if all the stakeholders are not agreeable. Now, that is the learning outcomes. Remember, we were talking about the learning outcomes, the role of learning outcomes. First, to identify the content. Second, to find out the teaching method. And third, the assessment methods. So after finding or identifying the learning outcomes and the content based on those learning outcomes, what are the teaching methods we can use? There are three models which have been recommended for teaching professionalism. Number one, experiential learning. Number two, reflection and reflective practice. And number three, situated learning. We will go into the details of each one of these teaching methods. About the experiential learning, the Cole's experiential learning cycle offers a useful model for teaching professionalism. This model offers learning through concrete experience and abstract conceptualization. I will further elaborate on these points. Cole's experiential learning cycle is a four-stage process that describes how knowledge is created through experience. I think this is the strong point in this experiential learning cycle, that how knowledge is created through experience. It emphasizes that learning is a cycle, with each stage building on the previous one. This is the diagrammatic representation of Cole's learning cycle. Let's start with the concrete experience. Means having experienced something, or after doing something, one reflects on that experience. And this reflection analyzes the experience, what we have learned from that experience, what has gone wrong, what has gone right, and then we modify that approach based on our reflection on the previous experience. And then we experiment, or we apply this modified approach. And then based on this abstract conceptualization, we assess this new approach, and the cycle goes on. This is a bit further elaboration on that. where these all 4 stages of Kolb's learning cycle are linked with the learning styles. Between concrete experience, which is a feeling, and reflective observation, which is watching, is the learning style of diverging, which is feel and watch are concrete experience and reflective observation. Between reflective observation and abstract conceptualization is assimilation. Between abstract conceptualization and active experimentation is converging and then accommodating. So this is complete cycle and complete set of instructions and learning styles which can help us in teaching and learning of professionalism in undergraduate medical education. The concrete experience means that it is the initial experience or encounter with some new or novel situation. It could be a new situation, a new task, or a reinterpretation of an existing experience. Reflective observation means that after the experience, the learner reflects on what happened, analyzing the experience from different perspectives. Then is the abstract conceptualization. Based on the reflections, the learner forms abstract concepts, theories, or ideas about the experience. And finally, active experimentation. The learner tests these new concepts by applying them in new situations, essentially creating a new concrete experience and starting the cycle anew. So this is the concept of producing knowledge from the experience. This cycle is iterative, meaning the learning process is ongoing and can be entered at any stage. To further elaborate this point, here are a few examples of application of Kolb's learning cycle. Let's look at these surgical instruments at the Victorian time. And now we look at the present surgical instruments, and we can see the evolution, the vast difference which has taken place over the time, and that is learning from the experience and modifying these surgical instruments. Similarly, these are some more instruments used by Arabians and the Muslim surgeons. Another example, observation of a professional behavior, then reflecting on that professional behavior, more awareness of experience, development of insight, seeking rationalizations, changing of perception and attitude, and finally, foundation of medical professionalism. So this is that starting from observation of a professional behavior as an experience and then reflecting on that and going through the whole cycle till we find the most appropriate professional behavior. Another example is the how to teach confidentiality to year 1 students using Kolb's learning cycle. Let's say the first step is planning, brainstorm for the views of these year 1 students on confidentiality, and how it should be addressed. Purpose is to activate prior knowledge, orientate and provide a framework and structure for the task. Second is the concrete experience, and that is where students interview a simulated patient with a scenario related to confidentiality. For example, revealing crucial information and insisting the student does not tell the medical team. So when students are interviewing this simulated patient, this patient shares an important information relating to his or her illness, but at the same time advises the students not to share this information with the healthcare team. So this is the point of confidentiality where year one students are going through that. And this integrates professional behavior with communication skills practice. Now, at the next step is the abstract conceptualization, means that the facilitator helps in the discussion of the group. Feedback and discussion provides opportunities for students' feeling and professional attitudes to be explored. Means now students are discussing, students are looking at the different points that there is an important information related to the illness of the patient, but at the same time, the patient insists that this is a confidential information and it should not be shared with the medical team. Reflective observation, the tutor reflects back guidelines for accepted ethical practice. So then there would be discussion that what the ethical requirement is needed at this juncture. The tutor links practice with theory, elaborating knowledge on legality and ethics of confidentiality. And finally, active experimentation, and students would reflect back that what they have learned from this experience and how will they approach such a patient next time. This prepares students for the next encounter and enables evaluation of the session. I think this is a very good example of teaching professionalism using the Kolb's learning cycle. And there could be many more situations where this approach can be adopted. Now let's move on to the second method, teaching method, which is reflection and reflective practice. Here is a beautiful definition of reflection. Reflection is a form of mental processing with a purpose and our anticipated outcomes. I think more I consider and think about this definition, more it gives me the idea of what reflection is. Let's just take a moment. Recall any one of your decisions changed after reflection. As a medical practitioner, can you recall any of your decisions which you changed after reflection? Just 30 seconds to think of any situations where you have to change your decision based on reflection. Here are 6 steps of Gibbs reflective cycle. First is description, then is the feeling, then is evaluation, then is analysis, then is the conclusion and action plan. In those last 30 seconds, the one you might have thought about an experience where you changed your decision based on reflection would have gone through all these 6 steps. The description of experience, the feelings, then evaluate the decision, analyze the decision, and making a conclusion, and then applying that conclusion. So this is Gibbs' reflective cycle. It has been argued that reflection on action is more useful than reflection in action for integrating learning on professionalism into the curriculum. I will elaborate on that. What does reflection on action means and what is reflection in action? Reflection on action is retrospective, means we reflect on an experience after the experience is over. And it provides us an opportunity for deeper analysis. Reflection on action allows for a more thorough examination of past experiences, considering what went well, what could have been improved and why. Drawing conclusions, this type of reflection helps identify patterns, develop new insights, and formulate strategies for future practice. And third, curriculum integration. By analyzing past experiences, individuals can identify areas where their professional knowledge and skills need development or improvement, and which can be integrated into learning objectives. So reflection on action has these 3 advantages and steps. One is deeper analysis, that we have gone through an experience and then we can analyze that. And based on that analysis, we can make certain conclusions. And then based on those conclusions, we can modify our curriculum or integrate those changes in our curriculum. This is reflection on action. Now, reflection in action, on the other hand, is concurrent. It's not after the experience. It is real-time adjustments. Reflection in action allows for immediate adjustments and problem solving during a task based on intuition and previous experience. Intuitive decision making. This type of reflection relies on quick thinking and is valuable in situations requiring immediate action. This type of reflection may not always be ideal for curriculum. It might be useful for other things, but not for development of curriculum. While essential, reflection in action might not always lead to the most conscious or structured learning for curriculum development. We see the difference between the 2 approaches. One is reflection on action, which is retrospective, whereas reflection in action is concurrent. And we'll see how these 2 can help us. The conclusion is, while reflection in action is crucial for practical application, reflection on action is argued to be more suitable for integrating professionalism into the curriculum due to its capacity for deeper analysis and deliberate learning. Please keep in mind, we are talking about development of curriculum for professionalism. And for that, it is argued that reflection on action is more useful. Reflection in action will be more useful in live examination of a real patient so that to avoid any harm. And reflection on action will be more useful while training students during a simulation, for example, in clinical skill lab. Right? So reflection in action is needed if there is something going wrong and is to avoid harm, whereas reflection on action is after the experience, for example, in simulation environment where there's no active harm involved, and then we can reflect back on that and make the changes. Therefore, a balanced approach incorporating both types of reflection is often recommended for optimal professional development. Both types of reflection in action or on action are useful at their own right, at their own points. The third teaching method of professionalism is situated learning. Students openly and freely deliberating on simulated or actual case scenarios. Vignettes based on professional or unprofessional behaviors. Thought-provoking incidents. Videos or pictures in a small group classroom setting under supervision of an expert facilitator is an example of situated learning. So here it is reflection on action. Now there are students who are sitting in a small classroom with an expert facilitator, and they have a situation under consideration. This situation may be a simulated patient or an actual case scenario, or is a vignette based on professional and unprofessional behaviors, or maybe a video or a picture or an incident. And now students are sitting there and discussing this openly and freely. So this is an example of situated learning. The situated learning theory recommends the presentation of information in authentic context. That means that all the scenarios or vignettes we are discussing in situated learning must be in authentic context. They should be real situations, real life examples which are under discussion. Situated learning may stimulate a healthy debate among the participants, and students may explore professional issues from their own perspective in greater depth. Here, there is an opportunity for students to express their own personal views and personal approaches, and then come to a shared decision. This type of learning is context specific through co-participation and with shared cognition. Students may also discuss a range of professional behaviors, both positive and negative, which they observe during their clerkship without identifying the personnel involved. I think this is an important and real life situations where students observe the behaviors during the clinical practice, which may not be exactly the same what they have been taught. And now this might create some disturbance at the confusion among the students. So there should be an opportunity for them to discuss this and find out the proper solution. So there must be an opportunity for students to discuss with any facilitator who should be able to manage this relatively complex environment with skills to negotiate interpersonal skirmishes. Having gone through those three major methods of teaching professionalism, which is experiential learning, reflection and reflective practice, and situated learning, there are some other methods which can also be useful. One is emotional intelligence. Training students in emotional intelligence helps them to improve their communication skills, teamwork and empathy, as well as academic performance. And we can see that these are some important attributes of professionalism. So training students in emotional intelligence can help to improve their professionalism as well. The second such method is informal curriculum, such as extracurricular activities and social interactions, may significantly contribute in the development of professionalism. So this means that whenever we are planning such events, extracurricular activities or social interactions, we should make a conscious effort and think what would be the effect of the activity on students in terms of learning of professionalism. Another method is the role model, and I think it has been described so many times. The contribution of role models in promoting professionalism has been valued. However, there are some issues. With varying cultural, social, and socio-economic backgrounds of students, especially in the international institutions, this informal process may not be sufficient, number one, or may even complicate the situation with students' different beliefs of what is professional and what is not professional in different contexts. As we have discussed in the beginning about the definition and scope of professionalism, the definition and scope may be slightly different in different geographical, cultural, or religious situations. So in that background, the role model sometimes may even complicate the situation because the behavior of the role model may be different than what students think about professionalism. The educational climate, role modeling, traditionally agreed but unwritten rules, routine habits, and rituals present in the medical profession are implicitly experienced by the learner, and this is termed hidden curriculum. We know that especially during our clinical work, there are a number of routines and habits which are practiced, but it's not really intended to teach the student, but obviously students are present there and they experience these things. Under circumstances, the hidden curriculum may be more impactful, and this impact may be positive or negative than really the formal curriculum. Therefore, it is imperative that the elements contributing to hidden curriculum must be studied carefully and dealt with accordingly. This means that we should look at our educational environment and the staff, the academic staff must be aware that whatever they are doing is being observed by the student and it can influence the behavior of the students. The negative point of hidden curriculum is that it may promote the culture that the boss is always right. The negative effects of hidden curriculum on learning may include loss of critical thinking, idealism, and ethical integrity. I think the important point is that as a medical professionals, as a teacher, as a clinical practitioners, we should be aware of this aspect of hidden curriculum and realize that this can both positive and negative effect on the training of the students. At worst, students may believe that they will be rewarded for imitating the unprofessional behavior of their teachers. In an uncontrolled environment, such as clotting patients in the hospital wards, learners are bound to observe inconsistent and less than exemplary professional behaviors. That is happening in hidden curriculum. Opportunities for discussion and guidance for reflection on such incidents should be readily available, and students should know whom to consult in such situation. When students observe a behavior which he or she think is unethical, is unprofessional, they need to discuss this incident with somebody, and that facility should be available. Digital professionalism, the latest, is a relatively new area, and students need to be guided to protect their personal information, to avoid joining inappropriate groups, to be mindful in sharing and watching photos and videos. They also need to be trained on how to search for authentic scientific information and judicial use of artificial intelligence facilities, and these also make important components of professionalism. Now, here is a situation just to think about, and based on your previous experience. If we have a patient, a lady who does not believe in any religion, and unfortunately, she loses her son, how do you think we can comfort her? Which would be a very, very different situation where when we normally face with our patients, we can comfort them based on their religious beliefs. But how would we do that? Somebody who does not believe in any religion. I think this can be a very challenging point even for experienced clinicians. Right? This is just to explore that how sometimes professionalism can be a difficult situation in our daily work. Right. So that is about the teaching and learning of professionalism. Our next outcome was about the assessment of professionalism, and let us look at this aspect. Obviously, to improve professionalism, its teaching and assessment must be formally and explicitly stressed in the curriculum. That's important. It should not be just believed. It should not be just thought that it's there. There has to be a formal and explicit effort to realize that we need to teach professionalism in our undergraduate curriculum. Having said that, we realize we know that assessing professionalism is perhaps one of the most challenging tasks in medical education. That's why that even after a number of reviews, no single conclusive method of assessing professionalism could be identified. However, there are many common approaches, such as using OSCE to assess professionalism, multi-source information, including peer assessment and direct observation by the faculty, or reporting of critical incidents and usage of portfolios. So these are few methods which are used to assess professionalism in undergraduate medical students. What are the common elements that need to be assessed? Here is a list: lifelong learning skills, altruism or selflessness, honesty with patients, confidentiality, improving quality of care, appropriate relationships with patients and their caregivers, proper and judicial use of finite sources, respect for others, ethical and moral standards, integrity, managing conflicts of interest, honor, accountability, professional responsibilities such as teamwork, leadership qualities, and preventing and managing conflicts, and understanding one's own professional limitations. I think this is very, very important aspect. The last point, that a graduate should know when to call for help. So knowing one's own limitation is very, very important attribute. So this is a list, some common elements. It may not be an exhaustive list, but these are the areas which should be assessed under the heading of professionalism. Now, how to assess these items? Because some of them may not fulfill the criteria of an outcome which is measurable or concrete. However, it is stated that observing external professional behavior may reflect internal attitudinal values. Again, this is a very, very important statement, that observing overall behavior of a person may reflect the internal attitudinal values. The assessment of professional behavior must be both for formative and summative purposes. It should meet the criteria of validity, reliability, acceptability, and feasibility like any other assessment. The findings should be gathered over time and carefully analyzed before an overall judgment is made. So means that we cannot make a decision based on just one trivial observation. Maintenance of portfolios, collating punctuality records, multi-source feedback, results of objective examinations, reflective essays on critical incidents, help in comprehensive assessment of professionalism. So again, these are some important views and important methods or resources which can help in the assessment of professionalism. Assessment need to be entrenched in the curriculum, and it must be integrated vertically as increasingly higher level of complexity as the trainee advances through the course. Right? So Difficult situations keep on arising along the way. Similarly, our assessment may be from simple facts in the beginning to complex situation in the later years, should be integrated vertically in the assessment plan. The tools for assessment of professionalism in undergraduate medical students include direct observation, multi-source feedback, reflective writing and portfolios, and critical incident reports and self-assessment. A number of instruments have been developed for assessment of different aspects of professionalism through different angles. For example, at the University of Michigan, a self-assessment questionnaire was developed for assessment of professionalism of residents in surgery. Based on the concept of mini CX, a professionalism mini evaluation exercise was developed, and a very useful tool. The Professionalism Assessment Tool, or PAT, was developed in Pakistani context using Delphi technique. The team-based assessment includes professional conduct, communication skills, teamwork, and accessibility. Other instruments include American Board of Internal Medicine Model or Framework of Professionalism, and it includes elements such as altruism, accountability, duty, excellence, honor, and integrity, along with respect for others. Four-component model emphasizes on psychological components vital for moral behavior. Dundee Polyprofessionalism Inventor focuses on students' perceptions and attitudes towards professional and unprofessional behaviors. LUPA, Liverpool University Professionalism Assessment, evaluates professional behaviors across domains like reliability, communication, and respect. Conscientiousness Index assesses students' administrative and academic behaviors, for example, punctuality and meeting deadlines. Defining Issues Test appraises moral reasons using ethical dilemmas. UHPS evaluates students' attitude towards various professionalism dimensions such as altruism and responsibility. And Situated Judgment Test evaluates professional capability and perceives students' expected behavior in their future careers. So you see, there are a number of tools to choose from. So based on the usefulness of these assessment tools, we can pick up one or two to assess our students based on our particular situation. Obviously, some of these tools may be modified to meet our institutional requirements. Having said all that, along with all the knowledge and skills, a strong commitment by the leadership and the faculty of the institution is vital to achieve success in teaching and assessment of professionalism effectively. Having all the knowledge and skills would not be successful unless we really have a commitment, both from the leadership and the faculty, to teach and assess professionalism, give it its due importance clearly in our curriculum. Only then we can succeed in our aim. I think with that, I thank you for your attention, and I will be happy to answer if there are any questions. I'll start sharing, and then we can
Assalamu alaikum.
Walaikum
Can
assalam.
can you hear me?
Yes, I can hear you. Yes.
I'm Professor Dr. Aftab Imtiaz, Head of Department Anesthesia from Karachi, United Medical and Dental College. My question, you have delivered a very good and informative lecture and very good preparation by you, and we have learned a lot from your lecture as well. And I will thankful for to deliver such a nice lecture. My question is how to implement all these parameters and gadgets in students teaching, training, and professionalism.
Right. Now, obviously, this is a very, very important question. First is the first step, as I mentioned, is learning outcomes. What we actually want to achieve. What is the criteria or attributes of professionalism in our situation? Even, for example, in one country, there may be different the requirements. So once the institution has to identify that what are the attributes which need to be taught, that would become the learning outcomes. Then we, as I mentioned, the three major teaching methods, and there are many others. Based on those methods, we can identify the content, what we need to teach. And if you are following an integrated curriculum, then professionalism, teaching of professionalism would become a vertical module along the way. So once you have identified all the attributes, then you can divide that which part you want to, for example, teach in year 1, year 2, year 3, year 4, and year 5. Obviously, the content and the complexity would keep on increasing in the spiral manner. And again, the assessment, the teaching and assessment have to be aligned. So the different methods, for example, we have mentioned an OSCE. Maybe one of the OSCE in your exam should be based on assessment of some attributes of professionalism. Or there may be the other very useful is portfolio. So these are different methods, and I think it's not really impossible. It needs little bit time and effort and discussion and a vertical module. In my one of the institution, we have been running this vertically. We used to call it personal and professional development module, PPDE, and we were really successful in implementing the program. I hope that answered your question.
Thank you very much, sir.
Yes. Any
Assalamu alaikum.
Walaikum assalam.
Professor Alam Sher Saab. Thank you very much, sir.
Yes, sir.
Can I make a comment, sir?
Sure, please. I'm waiting
Thank
for
you
that.
very much for your insightful webinar. Like always, you have certainly done a great job taking the initiative to deepen our understanding of professionalism in medical education. Actually, it's a crucial area for shaping competent, ethical future clinicians, I believe. I have a comment, sir, where I would like to hear your expert opinion. Actually, as we all know, that we are these days living in a digital era,
Right.
and a key challenge in medical professionalism today lies in integrating principles of diversity, equality, and inclusion while adapting to these demands of digital professionalism as well. So, as students strive to uphold these high standards that you have spoken for the last 1.5 hours, students or learners at different stages, they often face competing pressure that can lead to the stress and burnout, making it essential to support their well-being. And I think you might also have experienced that they demand some support from us as a medical education, as a mentor, to support their mental well-being as well. I would like to hear from your expert, uh, your experience and your expert opinion would be very much appreciated here on how shall our learners deal with this state of extreme burnout and keep their mental well-being intact while trying to uphold medical professionalism in today's era. Thank you, sir. Thank you very much.
Thank you very much, sir. I think that every one of us is facing that situation. All of us who are really working in the field, they face this situation. The one way which I see is the role of mentor. The mentee-mentor program can play a major role here. I give you the let's say two scenarios where we face the similar situation. Ours is an international school, so the students come from very different backgrounds. So something which is appropriate for one student may not be appropriate for another student based on their background. And sometimes they get really, really very upset. So that's one situation. Second, all of us, I think, are facing is this use of artificial intelligence, the judicious use of artificial intelligence. If somebody is using it in a wrong way, definitely they have a feeling of guilt that I'm cheating, I'm cheating myself, or I'm cheating others. I think in these are common examples, common situations, and our mentors have to be skilled enough to handle these situations. Now, like in we cannot say to our students that, for example, don't use artificial intelligence. We all know that would be a kind of useless instruction. So we, like for example, I'm dealing with when I don't stop them from using artificial intelligence, but I ask them that first try yourself. First write an answer or an essay or whatever it is yourself. Think about it so that your critical thinking is not affected. And once you have sort of exhausted yourself, then you can look for any other source. Basically, I use this artificial intelligence as another learning source rather than running away from that. So I hope that can sort of to some extent answer your question. I'm sure all of us are facing these situations and trying to find the solutions. Right. Any other comments or questions? Yeah, I think somebody is trying to use the whiteboard here. It would be better if you can comment verbally.
Assalamu alaikum, sir. So this is Dr. He's from Peshawar, Pakistan.
Yes, madam.
Sir, I will second your answer regarding the mentoring program. I truly believe that, yes, the mentee and the mentor relationship plays a very vital and critical role in shaping the student's mental health and, of course, in professionalism. But, sir, I think I must make a comment here that even if we have a very well-structured mentoring program, we need to train our mentors as well, because at times till first year and second year, when they don't have a very early clinical exposures, they are okay with everything. But as soon as they go and move towards the clinical exposure and they are in the clinical natural settings, then the things goes upside down. So I think we need to well prepare our mentors first, train them, and make them empower regarding all kinds of the situation where professionalism will work. So this is one comment. The second, sir, you did talk about the informal curriculum, that how it plays a very positive role in, giving some time to the students where they can learn different areas like leadership, like managing conflicts, like having good communication, like teamwork. So these all plays very important role while having informal curriculum. So we all believe that we have these sports activities, literary activities, social welfare activities, but when it comes to managing it at the end of the administration level, then it becomes hard to give them a lot of time. The student complains. So why it is happening? Because the regulatory bodies, they want us to finish the academic sessions timely according to the university's examination schedule. And plus, we need to look into the hours that are required by the regulatory bodies. And in fact, when we are applying to the international bodies where we have to, be registered, so they have certain limitations that we need to cover that hours. So meeting all those needs, we are somewhere compromising on the informal activities, and we always rush to finish the academic sessions. And honestly, when I look into the academic session, I hardly finish it like 36 weeks. It's always 31 and 32, and then the exams are scheduled, the professional exams are scheduled. So how would we address that to the regulatory bodies, that why are we rushing? Why we need to finish the academic sessions in 5 years? Why we are not thinking that we can slow down, we can give some time, give some space to the students so that they can have a good mental health and accept the very critical responsibilities that they're going to carry on with themselves in their future. Over to you, sir.
Right. Okay. So thank you very much for these important comments. Of course, the first, no, I don't think anybody would disagree with you that the mentors need training. Because the mentors should have a consistent and similar approach. It's not that one mentor is giving a different opinion than the other and students get further confused. In our institution, we have this training session twice a year, and it's not long, just maybe 2 hours in one session, and we talk about the broad the guidelines and the agreement. But having said that, we request the mentor that if they are in a situation where they think they cannot deal with that, they can always take help from, for example, somebody from administration like deputy dean, academic, or student affairs, and they can further take help from other departments, finance or others. So means that we train the mentors, but we still realize that mentors have their own limitations as well. So they are also provided a backup support if they need it. So that's number one. Number two, I think what you are talking about, the finishing the curriculum in time and rushing about it, maybe I feel you are talking about in favor of competency-based medical curriculum, where the time is not the factor for graduating, but it is the achievement of competencies is the criteria for graduating. So in that situation, some students may graduate earlier than the others. Having said that, even with the present curriculum with the 5-year plan, I think if we look at our curriculum, I wouldn't be surprised that you will find number of things which are redundant and being taught in the curriculum. And there may be a lot of duplication. So if we look at that, I'm sure we can save a lot of time which can be used in issues like what you have mentioned. I hope that answers some of your concerns. Okay, Professor Ahmad Mishwani, please.
Thank you, sir, for this excellent presentation and excellent subject. If you permit, sir, just a couple of comments regarding some questions. The first is about that hidden or informal curriculum and its effect on the bias or bossing of some of the faculty members. I think in most of the good institutions, even the hidden and informal curriculum has some limitations and some guidelines. So if the institutions follow some basic principles, I think that should not be a big problem. The next question is regarding this. You very rightly said that reflection on action and reflection in action. In your first sentence, you said that the reflection on action is better than reflection in action, but later on you clarified that it should be, I think, flexible and depend upon the situation. I will just quote at least uh, reflection on action may be more appropriate for theoretical or long-term programs, but reflection in action specifically uh, in the practice or actions, it may be very important. I will just quote two examples, one as an administrator and another as a clinician. Uh, one a patient was lost by a junior consultant, and when he was asked that why did you not call the help of senior one, he said that the senior most of the time said, even you don't know this thing and you called me, so we are scared to call him. And in this way, so I told him that you can later on say sorry and excuse from the senior, but the patient who has died, he cannot come back. And another uh, situation, similarly, a clinician was shouting on a junior person that you don't know this thing. The junior straightly replied, yes, sir, I am not a consultant so far. I don't know that why I have called you. So my suggestion is that the junior should not be scared of the senior to call or to seek help whenever they feel. And the senior should not mind if a junior seeks their help because he feels that he seeks help for the betterment of for the life of a patient. So these are just a couple of practical points which I have come across.
Thank you,
And
Professor
regarding this
Professor. Yes.
mentorship, the mentorships you, as you said, sir, in some of the institutions, this mentorship is handed over to junior faculty members, and specifically, as you have very rightly said, that the teachers must be trained about the mentorship, as well as the students should also be given some overview and basic know-how of the mentorship. What does it mean and what are the objectives? As in our institution, in Gandhar University and Kabir Medical College, me as a principal and as a professor of surgery, I take the mentorship classes, and our vice chancellor, Professor Ejaz Sankhatak, who is the vice chancellor and professor of pathology, he also takes the mentorship classes of first year and second year students. So if the senior faculty members are involved, then I think these things will be more productive. And thank you very
Thank
much,
you,
sir,
sir.
for the answer.
I think your points are very, very valid. Just want to mention about this informal or hidden curriculum. We know this is very useful, but at the same time, we should realize that it can have negative effects as well. So this means that we need to advise our teachers and clinicians to be careful, and their behavior should not be questionable in any situation, because students may carry a wrong message from there. Thank you very much, sir. Any
Thank
other
you.
questions or comments?
Thank you very much, sir.
Assalamu alaikum.
Walaikum
I'm
assalam.
Professor Dr. Atif Sitwat,
Yes,
and
sir.
I have two questions
Right,
and two suggestions.
right.
Number one, the question: what is the flip learning method?
Uh,
Number one.
Okay, let me answer that. Sir,
No, after that second question, you will answer one by one. So
okay.
I'm putting these questions simultaneously. One is the flipped learning method. Number
Okay.
two,
Yeah.
mini sects,
Right.
the assessment method for the students' assessment. Number
Right.
two,
Right.
I have two suggestions that such faculty training programs, they should be awarded with the CME credit hours, and a good certification should be done so that these such type of the activities can be beneficial to us in future also, so that our CV make should be strong by attending such activities. Number three. And number four, that all the faculty members, they should be trained according to the line that medical education is essential for them, and they should keep updated with the medical education by attending the workshop everywhere. Wherever they get such type of the knowledge, they should attend it in order to be updated in the knowledge of the medical science.
Right.
Thank
Sir,
you very much.
I will be very quick in responding. The flipped classroom means it's opposite what we do in our traditional lecture. In our traditional lecture, the students come blank and we teach them. So whole contribution is by the lecturer. In flipped classroom, it's other way around. The students are given a topic or material, they prepare, they come back in the classroom, they are fully prepared with that, and then the lecturer would assess whether they have understood, and lecturer would also answer if they have any questions. Lecturer may use different methods to assess whether students have learned that. They may use questions or examples. So this is what is flipped classroom. Mini CEX is, let's say, short version of classical long case examination. In this case, students is given a patient, and it's around 15 to 20 minutes. And the student is asked to take a focused history, physical examination, and in the presence of an examiner. And once student, let's say, finishes the history taking and focused physical examination, maybe in 10 minutes, then the examiner asks question on that and the management and related questions. So that is what is a mini CX. Your third question of issuing a certificate, actually situation is, sir, in these webinars, it is an individual effort. There is no institutional involvement. So as an individual, I don't think I can issue a certificate. It's only the institutions can issue the certificate. And so far, I have been doing on individual basis. However, we do conduct workshops where I involve different institutions and the certificates are issued. Your fourth point of faculty development, of course, lifelong learning, as we have been mentioning, is an important component of professionalism. And we, as a clinician, to give the latest treatment to our patient, I think it is our moral obligation to keep ourselves updated so that we can give the best treatment to our patients. I hope that answers some of your concern. Right.
Okay, thank you. Thank you very much.
Thanks, sir. Any other questions or comments by any of the worthy participants?
Thank you very much, sir.
Yeah.
Can you hear me, please?
Yes, sir.
Thank you very much.
Hasnan,
Sir, I'm Dr.
Bashir.
Hasnan Bashir.
Yes, sir.
I'm from Department of Medical Education and Cardiology, Sheikh Zayed Hospital, Lahore.
All right, sir.
Sir, thank you very much again for your efforts are highly regarded over here.
Thank you, sir.
And I just want to add few comments. We are practicing integrated curriculum over here.
Right.
And from very first year of the medical college, our students are experiencing with the PEARL, professionalism, ethics, research, and leadership.
Great.
And
That's great. Yeah. Mhm.
so our faculty is teaching them as a part of Pearl and assessing as well. Few points I would like to add, Madam Bilkis, I think, from Peshawar regarding informal curriculum.
Right.
I think this extracurricular should not be any more extra. It should be co-curricular.
Yeah, I think you're right. I agree with that. Yeah, it's a co-curriculum. It's not extracurriculum. Absolutely right.
Yes.
Yeah.
So
It is already co-curricular in most of the institutions.
yes, sir. Yes, sir. Just I would like that. It co-curricular mean with, as Sir Alamchair suggested, it should be with the proper learning objectives.
That's right. Yeah.
So that's the way how we can achieve the and assess the team building, leadership, all the domains of the professionalism, as I suggested. And in brief, the last slide of Sir Alamchair, commitments of the leadership and BN is very, very important. And we do have certain time constraint, and every institution have its own limitations. So we need to customize the things.
Absolutely right. Yeah.
Thank you very much, sir.
Sir, your point, because we know that the definition of, let's say, professionalism is not universal. It is regional and institutional because the values differ. The second, I think you made very important point that whatever activity we do, co-curriculum or others, there must be learning outcomes in our mind. And as we are addressing professionalism here, so we must think that how this activity is going to influence the aspect of professionalism among the participants. I think that's very, very useful approach.
Thank you very much, sir.
Thank
And
you,
once again, thank you very much for such webinars. We are in depth, sir. Thank you very much.
Thank you, sir. Before we finish, I just want to share one more slide, which I do in every presentation, and that is the this one, the charity drive. May I propose to each participant to donate $1 USD or equivalent amount in your local currency to any deserving individual in your neighborhood or any public welfare organization in your community after attending every webinar conducted from this platform. With that, I thank every one of you. Really, it was wonderful feedback and the questions raised and issues raised. And that shows your support for this activity. Thank you very much. See you next time, inshallah.
Thank you, Sir Alamchair, and
very
everybody.
much, sir. Excellent presentation.
Allah Hafiz.
Thank you.
Allah Hafiz, sir. Thanks. Thank you.
I will be sharing the video recording soon, inshallah.
Sure, sir. Thank you. Thank you.
Sir.
Okay, bye-bye.
Thank you.
Thank you.